Hey folks, well, thanks so much for joining the health policy track for the small group sessions. Can everybody hear me okay? If anybody isn't able to hear me, please just drop a message in the chat and I will see that there. Yeah, so just as a reminder to folks, this session is going to be recorded. Each presentation is about 10 minutes long, so I'll be providing a 1-minute warning as we get close to that time. And our hope is that we should be able to have some question time at the end of each presentation. And I mentioned this earlier, but please, while we're listening to the presentations, I'll ask that everybody keep their video and their audio off during the presentation. After which point we'll just ask the person who's presenting to begin. I'll also be going through the slides, so if you have any questions about that or any issues, please let me know if you're having any difficulty viewing. Okay, so without any further ado, perhaps I will introduce our first presenter, Nazrin.
Thank you so much, Alice, and hello, everyone. Happy to be here with you all, and welcome to this virtual session. My name is Nasreen Al-Ustaz. I am a first-year PhD student at the School of Nursing at McMaster University. And what I'm presenting today is a work that I've done for my master's thesis at McMaster, and I was interested to look at the experiences of registered nurses who are precepting new hired nurses into the pediatrics clinical care setting. So just to give a bit of a background, because the current curriculum does not actually guarantee placement of general trained undergraduate nurses into the pediatrics settings, and because the increased complexities and demands on our healthcare system, nurses might end up working in the pediatric settings and or being hired in the pediatrics healthcare institutions, and that would be their first contact with pediatrics patients or this population. So it does actually increase the pressure and load on the organizations of training these novice nurses, as well as increasing the pressure on preceptors who precept these nurses in those clinical areas. So from there, I was aiming to actually examine the preceptors' experiences when they try to, or they precept nurses within clinical areas in pediatrics care. And I was aiming to actually, or hoping to employ or recruit participants from 3 different departments in specialized areas. So my aim was to understand their experiences and to uncover some of their demands and needs, and some to come about with some recommendations for the institutions and for preceptors to carry out their role effectively. To answer my research question, I've used an interpretive qualitative or an interpretive descriptive research method for all its underpinnings, the assumptions and underpinnings underlying the interpretive descriptive method, as well as to produce knowledge that can be applicable to practice or to clinical practice. So with this research, I initially contacted all 3 departments, clinical nurse managers, after I got ethics approval from the Hamilton Ethics Board and from the Neonatal ICU Research Committee. The 3 department managers and educators were welcoming to meet with them. The research took place, or the meeting took place last year in March. And when I started the recruitment or distributing flyers for recruitment, it was amidst the quarantine time. So there was loads of difficulties, recruitment, getting to meet people face to face, especially when we went into quarantine. So one nurse manager I was able to meet face to face, and then I was able to email another person, and then the third I was talking to her over the phone to explain my research and the aims of my proposed study. 10 nurses were willing to actually participate in the study. They were all from the neonatal ICU. The other 2 departments were not able to participate due to the COVID-19 impact on those departments. 5 nurses were recruited and accepted to participate in the interviews, and 5 others actually dropped out due to their commitments to work and busy department as well. So it was really a challenge. Participants received information before we interviewed them, and amendments and modifications were made to the protocol. Ethics approval was obtained, as well as nurses were informed of those amendments. And I started the recruitment and interviewing between March and end of April 2020. The research was analyzed, the data were analyzed, and I followed the Brown-Clark's framework to analyze my data and to get into my findings. Trustworthiness and rigor also were followed, and most importantly, the participants' confidentiality. The group then, the demographic data from my group, there were 5 nurses, 3 of them were experienced and 2 others were novice nurses, and 2 out of 5 nurses did receive training for preceptoring, the preceptorship role. So some of the themes, or the themes that I came up with, there are 3 major themes. All nurses or all participants perceived that their job was a dual job. They had a bedside nursing role, and they have an educator preceptor role for their nurses. They were able to describe their experiences. The one major sub-theme that stood out for us was that it is really rewarding. However, it is hugely challenging. I was able to extract all the challenges from 5 participants, and the one major challenge that they faced, they were not trained, they were not prepared to take the job or the role of a preceptor. And the last thing, there were some interesting themes came up that experienced nurses didn't like to precept experienced new hires, and vice versa. And novice preceptors didn't like to precept novice and new hires. And the reason was because new preceptors felt the more experienced new hire is more tuned into healthcare setting and chronic or acute healthcare setting. However, the seasoned preceptors presumed that or perceived that new preceptees were more kind of receptive to training and more kind of wanting to learn and to have hands-on and more understanding of the new environment. So that was kind of an interesting finding. And they were able to list loads of needs during their or when they're carrying out their role. One major need is to get trained. However, they want to be offered the education day during their time, like it's a paid off time, where now they are not paid off and they're not willing to take the time to learn about preceptorship during the day off. So that was kind of one major demand. And another one is great support from managers and educators. There were limitations, as I mentioned earlier. The study was carried out during the COVID-19 pandemic. So recruitment was challenging, accessing health, the acute healthcare was challenging too. However, the strength is that this study used an interpretive descriptive to delve deeper into their experiences, as well as this study was carried out in a unit where there was a huge recruitment, nurses leaving in nursing, nurses like overturn was major. So it was rich in from that regards, from the information. At the end of this study, we were able to make recommendations for organizations and for educators as well, and for future research. So this is, in a nutshell, the study, and I'm happy to take any questions that you may come up with. Thank you so much for listening.
Thanks very much, Nazrin. So we have 1 minute for questions. Does anybody have a question? Hearing none from the crowd, I wonder if you could just speak briefly to your choice of interpretive description as a methodology. And in particular, I'm wondering if there were any specific challenges. But actually, in the chat, I'm seeing the question. Hi, I'm an RN at cardiac care, and I'm wondering if the findings would be similar or different based on the clinical setting. So maybe you could just answer that one in 45 seconds.
Yeah. Thank you so much for the question. That's a good question. And as I mentioned during my presentation, there was a big challenge of recruitment. The main aim was to recruit nurses from different departments. However, due to COVID-19, I was restricted, and that I mentioned that during in my limitation section. And future research would really be greatly interested to see what other departments and other specialties. The neonatal ICU is kind of a unique department in which there are loads of similarities probably in the cardiac care unit, and that it's busy and it's highly demanding unit. The acuity of patients are really high, as well as nurses who might be employed into the cardiac unit. This is their first contact, maybe. So it is similar from that kind of term, but it would be interesting to look at the different experiences from different perspectives and different specialties. And I believe there might be some differences. The bottom line for the whole preceptorship role is training and support from managers and educators. I hope I answered your question, but yes. A reason for choosing my interpretive descriptive method is that this methodology actually first provides me the assumptions allow me to delve in deeply into the preceptors' experiences and uncover the underneath and find out their constructed realities of what they experienced. The second thing is allowed me to actually come into recommendations that are applicable, actually construct a theory that is applicable into practice. And that's one of the main underpinnings of IG. So it did help me walk me through. One challenge I faced is that because of the small sample, the interpretation was really difficult. And I agree with Arunima, I hope I pronounce your name right, that if I had different participants from different departments, that probably will help in uncovering more experiences as well as interpreting the themes in a better way.
Yeah. Thank you so much, Nazreen. That was a great presentation. So now I just want to briefly greet everybody else who has joined us since since we started. This is the health policy track of presentations. Please keep your screens off and yourselves muted while we're just listening to folks present. And you can ask questions by writing in the chat or putting your hand up at the end of each presentation. So Jillian, you have 10 minutes. I'll give you a 1 minute warning, okay?
Sounds good. Good morning, everybody. My name is Jillian Lopez, and I'm currently a research assistant here at McMaster. I've just recently finished my bachelor's degree in health sciences this past April, and today I have the honor of sharing my thesis work with you, which explored the impact of gender on postgraduate resident experiences in psychiatry. Now, residency is a unique transitional period during which residents maintain simultaneous roles as clinician and learner as they encounter a critical junction in their career. While they're beyond the point of being medical students, they have yet to achieve the status of independently practicing physicians, which they of course aspire to be. With this in mind, with the help of my incredible supervisors, I sought to better understand how gender plays a role in this phenomenon and how it impacts a trainee's clinical, academic, as well as research experiences during the challenging period that is residency. So semi-structured interviews were conducted with postgraduate psychiatry residents affiliated with the Department of Psychiatry and Behavioral Neurosciences here at McMaster, in order to explore participants' individual perspectives regarding how gender has impacted their training. So with that, 6 themes were identified from the interview data, namely, stark contrast between a man and a woman's ability to identify gender-related experiences, a woman's duty to care, women as homogenized, the notion that equal is not equitable, the existence of tensions for women trainees, as well as future-oriented solutions. On the poster, as you can see, I've included a few of the many striking quotes collected from interviews with participants, a few of which I will speak to in relation to some of the major themes. So study findings highlighted a striking discrepancy in the extent to which women and men were able to identify the ways in which gender impacted their professional and academic experiences. Participants were asked about how gender may impact different realms of their professional lives, those being academic, training, teaching, clinical, as well as research experiences. And participants who identified as men reported a minimal impact of gender on such domains, or could not easily identify specific advantages or disadvantages conferred as a result of their gender. Women, on the other hand, were able to identify a plethora of gender-related issues that they had encountered within their professional experiences thus far. One of the major themes from the study findings discusses a woman's duty to care. While caring seems to be required of women, it is very much undercompensated. Caring in psychiatry might be assessed by the time physicians spend with their patients, really being thorough to truly understand a patient's concerns. For women, caring appeared to become synonymous with being good at something. Men, on the contrary, could often get away with spending a little bit less time with their patients or conferring with colleagues and not have their legitimacy as a respected physician questioned at all. The same wasn't necessarily true for women, according to study findings. Specifically, participants who were women often pointed to differential standards and expectations for behavior among colleagues and supervisors who identified as men. Women participants reported noticing that their counterparts who were men typically spent less time with patients and conferring with nursing staff. On the contrary, women reported feeling a drive to really be thorough and invest themselves in their patients' treatment, while also being more willing to adopt collaborative approaches to care with allied nursing and other health staff. However, study findings suggested that the tendency for women to take on this duty to care came at a considerable financial, emotional, and professional cost. Furthermore, one participant who is a woman noted women in medicine need to be a certain way, to be respected and taken seriously as a physician. Another claimed, I'm not supposed to speak out of line or speak my mind or be brash, which is exactly what's been modeled to me in the male supervisors that I've worked with. Within medical education, participants noted the existence of a seemingly implicit process of homogenization for women trainees. Women participants reported perceiving a tacit expectation to embody what is more traditionally considered as feminine and to fulfill traditionally feminine roles. As a result, women participants reported having to frequently contend with gendered stereotypes and noted feeling as though the qualities that they can embody might actually be predetermined. It goes without saying, this process of homogenization throughout medical education vastly undermines the value of diversity as well as intersecting identities among women trainees. Moreover, women participants noted the presence of gendered stereotypes, specifically how men were more often associated with respect and authority. Participants explained how a man's status might be viewed differently than that of a woman's, as men may be deemed as more respected within clinical contexts and may be less likely to be questioned with respect to their recommendations for a patient. One participant who identifies as a woman noted, in psychiatry at times, it's a little bit easier because we are more of a female-dominated profession, but I don't think it really mitigates the impact as much as you would expect, given the proportion of women in psychiatry compared to men. I find that it still feels unfortunately like the men do get taken more seriously and seem to have more authority naturally, even when they're up against some very, very competent women. Furthermore, all participants of the study, both men and women, noted the high frequency of trainees who are women being incorrectly assumed as a nurse, a stereotypically feminine role, instead of a resident physician, a stereotypically masculine role. To achieve equity, participants noted that institutions should consider analyzing how physicians are compensated and rewarded for their time and make any necessary adjustments to ensure that equity is achieved. While men are described as using an efficiency-oriented model that is highly compensated, women reported feeling as though they are not accordingly compensated for their efforts, quantified by the increased amount of time they might spend with their patients. Overall, it's important to note that equal is not necessarily equitable. Equal representation in terms of numbers, which is often the metric used to evidence equity, does not accurately depict equitable treatment amongst trainees with differing gender identities. There are qualitative differences between a man and woman's experience, and these should really be recognized. So to combat this, institutions are encouraged to adopt gender-informed education and teach with gendered lenses in order to really help everyone better appreciate the unique ways in which gender can impact the many realms of a trainee's professional experiences. Thank you so much for your time and attention, and I'd be more than happy to answer any questions.
Thank you so much, Jillian. This is really fascinating and interesting work. In the chat, I'm seeing that Sam has a question. So the question is, if I'm not mistaken, this work is epistemologically constructivist, and as such, depends on the individuals within the study. I'm curious if you have any insight into research that shows measures of performance or attainment in psychiatry, i.e. job placement or monetary compensation. I understand that my question is not epistemologically within the realm of your work, which is a good caveat, but any thoughts on that?
Yeah, according to data from Ontario, monetary compensation-wise, women physicians, specifically psychiatrists, tend to earn approximately 20% less on average, of course, to their male counterparts in their field, which has been presumably attributed to the fact that they tend to work fewer hours, they may see less patients, or they may take more time for personal leave. However, a recent study actually did a regression analysis on that, and they found that those three reasons that are often cited in the literature really only account for 20% of that variance in average compensation, and the other 70 or so percent is actually attributed to some unknown factor. So I always found that to be a really interesting finding, and it certainly leaves a lot of room for further reflection on such topics.
Thanks so much, Jillian.
Thank you.
Not seeing any other questions. One question that I had was, to what extent did the folks in your study, did your participants comment on psychiatry as a factor? Given that all of these folks would have had the opportunity to experience other specialties in the course of their medical training. Did anybody have any insights about how psychiatry shaped their experience and the interaction between gender and their specialty?
I heard from a few participants of mine, especially from the women participants, they felt as though in their medical training that psychiatry felt very accessible, and there were a lot of incredible role models to look up to, and they really felt as though they could see themselves long-term and being successful in psychiatry on both a professional level with their patients, as well as being able to attain some really incredible feats within their professional careers. And that notion, to an extent, was almost a little bit shattered when they got into the department. And it's quite fascinating to think about that and consider that in more detail, only because, psychiatry does feel very accessible, and it is a faculty where, these affective traits and these compassionate traits are really encouraged. So it's always fascinating to hear these participants' experiences given those considerations.
Thank you so much. This was really interesting work.
Thank you, Alice.
So next up, we're going to hear from Anahita.
Yep. Hi.
Wonderful.
Okay, so I can get started here. My name's Anna. I'm one of the residents here at McMaster. And this project I worked with Dr. Clarkin as well as Dr. Doja. Dr. Clarkin is a researcher at CAMH, and Dr. Doja is a pediatric neurologist at CHEO. So my project involved trainee perceptions of resident duty hour restrictions, and it was a qualitative study of online discussion forums. And just given the nature of how unconventional online discussion forums and doing research on these forums as a source of data was, I really enjoyed this project. So I'm really grateful to be able to present it here. So just a bit of a background, resident duty hour restrictions has been quite a prevalent, I guess, hot topic in quotations in the past 2 decades, at least in the States, and probably pre-pandemic, it was more of a hot topic in Canada. And globally, there are various restrictions on duty hours for residents. In Europe, they actually have the European Working Time Directive, which essentially they can work only 48 hours a week, and that applies to residents. They don't do 24-hour call either. And in the States, they have the ACGME resident duty hour restrictions, and those are essentially a set of criteria which have actually been revised twice now, which restrict residents to working 80-hour weeks and but does allow for 24-hour call. And in Canada, we don't have a national resident duty hour restriction rule. However, we do have the Quebec ruling in 2011, which restricted residents to 16 hours. And then we also have the PARO rules, which do provide some guidance on the weekly hours. Now, these topics have heterogeneous evidence behind them in almost every aspect of resident wellness, of competency. And there are a lot of trials and studies out there, but most focus on either expert opinion or they focus on really conventional ways of trying to get that data, like focus groups and surveys. And I wanted to get more of an authentic voice and, non-judgmental kind of voice from trainees. And I thought that these online discussion forums are actually a really good source of that information. So in the States, we have the Student Doctor Network, and in Canada, we have the Pre-Med 101. I'm sure some of you guys have heard of these forums. They essentially post anonymously about various different topics and discuss them there. So I wanted to do a qualitative analysis of the content from these forums around resident duty hour restrictions. And my methods was we did an initial scan to determine the relevant keywords. We did a keyword search on each forum, and then we did an inductive analysis of the extracted threads. And to ensure reliability, we also co-coded a sample with Dr. Clarkin, who's a qualitative research expert. So across both forums, we looked at a total of 6,630 posts, and most of them, over 6,000, like 6,200 were from the SDN. So as you can tell, in the States, they've developed this much more than we have here in Canada. The three themes that came from this that I'll talk about in this presentation, but of course there were more. The first one is the role of hours and competence and learning. And this was really interesting for me because a lot of these discussions discussed that, blanket rules don't apply to all specialties. Specifically, procedure-heavy specialties often need more of an immersive experience where longer hours do actually make a difference in their training, as well as in the continuity of the care that they provide for their patients. And one of the quotes from that section is, you can hand off a medicine patient waiting on a CT scan to another team. You can't hand off a Whipple procedure to another team. Surgery residencies are smaller than medicine residencies. Patients are sicker and they operate in addition to managing them medically. The second sub-theme that came out of that was the fact that nighttime coverage and call is extremely important for developing independence as a clinician. And this particularly came into effect when for a couple of years, residents or interns in the States were restricted to doing only 16-hour call where they couldn't stay overnight. And so one of the quotes from that is, being there at night forces you to make decisions on your own. It's like learning to ride a bike. Sure, you can go through the motions, but until those training wheels come off, you aren't really riding a bike. And the other theme was patient safety and medical error. And this one was interesting because a lot of posters did talk about handover issues arising from restrictions on duty hours, but they also said that medical errors and specifically fatigue-related medical errors also come from longer hours. So kind of goes both ways. And there's a quote here in the context of a senior medical resident or a self-identified senior medical resident responding to codes. And they say, especially at night, when I ask a primary team caring for the patient for their history, I'm answered with a rapid shuffling of papers because no one personally knows the patient. So often when they go to a code and the night team is covering, nobody really knows the patient, so it's harder to respond to those. And perhaps the most unexpected finding that I found from the study was the problems with adherence to resident duty hour restrictions. And this was quite prevalent across specifically interns when they have just entered residencies, and they found that their schedules did not adhere to these restrictions and how they go about reporting them, reporting these violations. And interestingly, when people posted about advice for that kind of a situation, most people said, don't tell, just don't tell, wait for this to end. So a quote from that is, if you log a violation, things will only be worse for you. I've seen this firsthand. Do not get your program in trouble for this. They will make it hell for you. You will get no job recommendations. You will be labeled as entitled and lazy. So that was probably the most jarring theme that I found from this project. And so some of the implications of this are that if we were to develop a national resident duty hour restriction policy, we need to allow flexibility in the development of these restrictions across specialties, but also within programs, depending on the size of the program, where it is. And the second thing is we need to have a psychologically safe and standardized procedure for reporting duty hour violations. And the last thing is there was a lot of discussion on these forums about the number of hours not being the primary factor in things like resident wellness or patient safety, but that, as we know from a lot of literature, that there are systemic level factors that need to change in addition to our to resident hours. Thank you so much for listening to this talk.
Thank you so much, Anna. This is really fascinating work. We have a couple of minutes for questions now, and maybe I'll just get started. Feel free to put your hand up or type in the chat box if you have questions. I'm curious, what surprised you the most in your findings here? Was there anything that struck you that didn't sort of cohere with your expectations and what you thought you might find?
Yeah, for sure. I think because we don't have resident duty hours in Canada, a lot of it was quite alarming, but also the adherence section that I was mentioning and how, how not straightforward the process of reporting a violation is, because, in a trainee's mind, a lot of things go through their mind. It's not just, I'm going to report this and the program won't schedule me in like this anymore. It's a lot of things like, if I report this, maybe they will find out who I am, and maybe this may affect my future as a physician, because the program might vouch for me in terms of getting jobs. And I thought that was quite it's something that it definitely didn't feel like psychologically safe if there were violations. And the fact that there are violations, right? You think rules and people would have to adhere to them, but it seems like that's not the case. So it was very interesting.
Yeah, absolutely. I think I'm sort of feeling a lot of resonance with some of the work that I've been involved in related to mistreatment and the trepidation that folks feel about reporting their experiences of mistreatment because of the concern that they'll have blowback from their preceptor. Any last quick questions from the audience here? Okay, I just want to say thank you so much for taking the time to share this work, and really excited to see this push forward. Okay, so the next we're going to hear from Sherry and Lan Yi. Do I have you both in the call?
Yes.
Wonderful. Okay, you can take it away now.
Okay. Good morning, everyone. My name is Lanny. I'm a McMaster student in the class of 2023. I'm here with my colleague Sherry from the class of 2022, and we're going to be discussing parental leave policies in Canadian surgical training programs. This project is led by Dr. Anita Asai from the Department of Psychiatry and Behavioral Neurosciences here at MAC, along with the help of Drs. Reed and Dr. Sonodara. So for decades, there have been some calls to implement parental leave policies for physicians. Some progress has been made, but policies are highly variable across sites, unclear or unspecific. Taking parental leave can be especially challenging in surgical specialties, which usually have lengthy training and fewer residents per program to cover for those on leave. Often surgical training years coincide with the age at which many individuals of the general population would like to have children. The decision of when to have children is therefore multifactorial for each individual. Of the studies that have examined parental leave policies at academic sites in Canada, few have focused on surgical specialties, and even fewer have looked at non-childbearing leave. So that would be paternity leave or adoptive leave. So the objective of this study was to look at parental leave policies, both childbearing and non-childbearing, at Canadian academic surgical centers, as well as perspectives on these policies and the effects of becoming a parent on one's surgical career. We had an online survey sent to surgical department chairs and other residents, fellows, faculty, program directors, and division heads back in 2019, and 182 responses were received. The survey was multiple choice with an opportunity to comment at the end, and we analyzed the responses through descriptive analysis. And now I will pass it along to Sherry.
Thanks, Lanny. So next, I'll be going over some of the key findings and major takeaways from our research. So firstly, regarding the leave for the childbearing physician, most of our respondents had identified that the ideal childbearing leave time is 9 to 12 months. However, we found that the time that they or their colleagues in the programs had reported that they actually took off for leave was about 1 month or less. So we found that this actual time off taken by surgeons was significantly less than the average duration of parental leave found in past studies across all physician specialties, which the mean was about 9 months of mat leave, or equal to the ideal time taken off. Secondly, regarding non-childbearing or partner leave, there was an interesting bimodal distribution that we found, first peaking out 1 to 3 months, and then again at 9 to 12 months. And so when we analyzed this discrepancy by role, we found that residents and faculty were the ones that were more in favor of the longer period, while administrative roles such as program directors and division chairs favored the shorter time off. And we thought that this may indicate a shift in perspectives in favor of a more work-life balance and breaking traditional family roles amongst the newer generation of physicians and residents. And this is in accordance with another study that we found from 2020 that found that more residents and recent graduates are taking partner leave than staff surgeons had done in their same residency program about 5 years ago. However, more than half of the department chairs that had responded to our survey still reported that their program lacked a formal policy regarding taking non-childbearing or partner/adoptive leave. So this is an area where there is a lot more work to be done. And then next, regarding when to take leave, there was a perceived negative effect that we found on physician well-being when taking parental leave during residency as compared to during the faculty years. And this is also inconsistent with past studies which noted similar barriers to taking parental leave, including stigma, financial strain for the family, added burden for fellow colleagues, impact on skills and training, and also not wanting to delay or extend training time. So our respondents identified that they don't want to burden their colleagues during their own time of parental leave. However, we found that when programs fail to hire a locum to replace them, that their fellow colleagues will have no choice but to take on more workload than desire to cover for them, and they find themselves in a situation where their hands are tied. And this is especially true as of residents in our current medical system, because residents typically are not covered by locums and are covered solely by their co-residents who are in the same rotation as them. So we think it's really important that programs start fostering a culture that supports taking parental leave and preventing physician burnout during this unique time in their lives. And lastly, we looked at policies which support new parents in Canada in the Canadian surgical programs, and we found that according to our respondents, this remains a very gray field for them. There was a significant amount of uncertainty regarding the present parental leave policies that exist, and also any return to work policies such as breastfeeding. We found multiple pre-decision studies that have also alluded to how an effective return to work policies, such as advocating for daycares near hospitals or having protected time and space in the hospital to breastfeed, how these things can alleviate the impact of being a new parent on this physician's career. So to wrap up a bit, some of the limitations of our study were that most of the respondents that we had received were from Ontario. So some of the provinces across Canada would have been underrepresented in our study. And as well, in the methodology of our study, we mostly used multiple choice questions, which unfortunately cannot encapsulate the exact opinions of some of our respondents. However, we tried to take into consideration some of the comments that were left and noted any repeated patterns into our discussion. So to conclude, the bottom line of our study is that there still remains a lot of internal and external barriers to taking parental leave in the surgical field in Canada today. Surgery was a very male-dominant field for a very long time in the past. However, many new studies, including our own, are showing some evidence that it's time to take some change at an institutional level to ensure that we're supporting our physicians and that physicians of any gender are able to incorporate having a family into their life and their career if they so wish to, without putting extra stress and jeopardizing their career. So thank you for listening to our presentation, and then we now open the floor to any questions.
Thanks very much. I'm seeing that there's been a lot of chat, and I think I'm like, maybe I'll call it outrage or shock, maybe about how low the time that folks took off was. While folks are formulating their questions, maybe I'll just ask a first question. In the course of your literature review, did you see, so this is a nationwide study in Canada, did you get a sense of what the range of times that folks might take off in parental leave and particularly in childbearing leave? Did you get a sense of how the Canadian context compares to international comparators?
So my lit search focused mostly on parental leave policies in Canada, but I did see earlier on that some American studies, they were reporting much shorter parental leave policies. So the one that Sherry mentioned across all specialties in Canada was around 9 months was the mean, and American ones were definitely shorter because they have less protected time off. And then funny enough, in those American studies, they would mention or allude to the fact that like, oh, in Canada, people usually take longer leaves. So I think someone else has mentioned this too, but so you get EI. If you're a resident, you get EI during your leave, as well as the Paro top-ups if you're in Ontario, and that can cover like a significant portion of your usual salary. But there aren't really those things in place in America, or like not to the extent of what it's like in Canada, as far as I know in my very limited research.
Thanks very much. That's really helpful. Well, again, and please feel free to jump in if you have any other questions by either raising your hand or typing directly in the chat. The other question that came to mind while thinking about this was about this point of locuming and the like finding locums to cover leave. It's my understanding that there's a surplus of surgical staff or trained surgeons in Canada right now. Did any sort of broader questions about the impacts of parental leave on health human resource planning come up in the course of this study?
Yeah, we did look a little into locums and like hiring locums, although we're unsure of like the kind of idea of having excess surgeons. However, it seems that the idea of locums is much more utilized in non-surgical specialties, such as, hospitalist or primary care, where, it's much easier. I think it was alluded to in a previous talk, but it's much easier to hand off care and share care in that sense. Whereas in surgical specialties, despite having this kind of perhaps lots of surgeons, it's hard for them to hand over the care of their patient who they've kind of followed up to another patient. So locums are not actually used as often in surgical specialties at the moment.
Okay, thank you very much. That's very helpful. Yeah, so I think folks on the call are very excited about this work, and thanks very much for taking the time to share with us. So now, last but not least, I'm going to introduce, I guess this would be Lawrence Grierson to take us away and to talk through our last study here.
Hi, am I audible, visible?
Yes.
All right. Thanks so much. This has been a great session. I've really enjoyed it. I'm gonna brag a bit. We've seen a lot of Anita Kai on these presentations, and she's one of our health sciences education graduates. So it's nice to see the trajectory take us to such great work. And for the HSED students in the room, I hope it's inspiring. The research I'm presenting today considers the challenge of distributing family physicians to ensure equitable access to healthcare. In particular, it scrutinizes two educational policies that are held up as promising and influencing what we call the geographic disposition of physicians. This is the selection of medical school candidates from particular regions and the establishment of clinical education in underserved areas. I'm presenting this work along with my co-investigators, Dorothy Backer, Gina Agarwal, Monica Agarwal, and Neil Johnston, and with the support of Mira Mahmood. The study is conceptualized in two parts, each addressing one of two objectives. The first is to describe the degree of association between the places from which McMaster University medical trainees apply to medical school, the location of their undergraduate medical school assignments, the location of their postgraduate residency experiences, and ultimately the disposition of their physician practice. And with specific respect to indices that describe those geographic areas in terms of socioeconomic determinants of health and notions of high physician need. We are doing this with consideration for only those McMaster trainees that progress through CFPC accredited residency programs and into independent family practice. The present poster, what I'm presenting here, highlights early results from this part of the study. The study's second objective is to develop a refined description of the mediating factors that influence and constrain the relationships between origins and training locations of family physicians and the places that they establish their independent practice. This objective is going to be addressed using qualitative methods, and it's just getting underway now. So I'm not going to be presenting that part of the research in this presentation. That's for NERD 2022. So our methods, we collected relevant administrative data pertaining to individuals who entered the MD program between 2010 and 2015 and went on to complete a residency program. The data included information about the student's age and gender and the postal code associated with their residence during high school, their pre-clerkship training, their family medicine clerkship locations, the location of postgraduate training, and the location of their independent practice, of course. The location data, the practice location data, were acquired via the physician registry maintained by the Ontario Physician Human Resource Data Centre. The time period we looked at included just over 1,000 McMaster graduates, closer to about 1,010, and yielded just under 350 individuals who were represented across all relevant time points, from admissions to practice. The postal code data for each trajectory point was then used in conjunction with Statistics Canada's postal code conversion file plus, the PCCF plus, to index the locations with respect to a number of indices associated with the Stats Canada Health Region Peer Groups construct. In particular, the geographic characteristics in terms of urbanicity or rurality, the employment rate in that area, the proportion of Indigenous persons in that area, and the proportion of visible minorities in that area. Postal codes were also used to index the areas according to their relative national income quintile, which we used as a marker of the community's socioeconomic status. This is also generated by Stats Canada. And as well, the ambulatory care sensitive condition rates for that community. And the ambulatory care sensitive condition rate is a count of the number of inpatient visits or hospital admissions for conditions that can be reasonably managed via outpatient services. And these data come to us via CHI and stand as a marker of the quality of primary care in a particular location. The idea being that these numbers should be low if there's a strong primary care system in that space. With all these data collated, this is the point we're at now, we are moving through a process of building logistic regression analyses to determine the degree to which the characteristics of a physician's origin or locations of training are associated with their eventual practice. The idea is to extend the inquiry regarding physician maldistribution to consider more deeply the way that community features above and beyond rurality drive downstream choices about practice. These analyses will include uni and multivariable approaches, tests of collinearity between indices, and the analysis are currently underway, and I'm not in position to provide a full outlay of findings here and now. However, in the poster, we do present a table that shows some simple relationships between the urban and rural nature of MAC-graduated family physician experiences. And the urban and rural nature of their eventual practices. So to summarize, those that come from a location described as a mixed urban-rural community or a rural community are significantly less likely than those that come from an urban community to establish practices in an urban location. And similarly, those who complete postgraduate training in an area characterized as mixed urban or rural, which is about 40% urban and 60% rural or rural, if you want to just shorten it all up, or rural, are less likely than those that trained in an urban area to establish practice in an urban area. So this lends credence to the idea that selection policies that dedicate medical school seats for those from rural areas may promote physician practice in rural areas. And the same thing with distributed education models that place learners in particular areas. However, this seems to be largely the case for residency training so far in terms of our analysis, but not undergraduate training. And there's more work to do to understand how other community features, such as socioeconomic status or the proportion of visible minority in an area, also affect practice decisions. And we're working through that. So I can imagine you're all thinking that there's just so much more going on here that's at play. And that it all might interact to drive practice behavior, and 100% we agree. This is just a simple first demonstration of association. As I said at the beginning, moving forward, we'll build multivariable analyses that consider the ways in which these indices may coalesce to have an influence. And we are also embarking on qualitative work to understand the way that education factors intersect with other personal and professional factors to influence the choice of practice location. We anticipate that family considerations, financial and remuneration structures, practice preferences, and just where are the professional opportunities will all factor in as potentially meaningful. I'll stop there and I'll take some questions, and I thank you for your attention and your interest.
Thanks very much, Lawrence. Feel free to write your questions in the chat or to put up your hands. And perhaps while folks are doing this, I'll just ask. So we've talked a lot about, I'm seeing Savannah has a comment writing, interesting. Is that difference identified between the impact of residency and clerkship training on final location, possibly due to the difference in length of time spent in a rural community, i.e. 1 block in residency, which is typically 4 weeks, versus an elective medical school as short as 2 weeks? Do you have any thoughts on that, Lawrence?
It's quite possible. As you can imagine, in our data set, we have numerous times in the aspiring physician's progress through undergraduate and then into postgraduate training and into practice where, they spend variable amounts of times in various places. Postgrad residency tends to have a longer stay, and that can definitely be effect. We're gonna dig down at that. We've had to make some analytic decisions with our modeling in order to denote people as having a rural or an urban-rural experience, and are not able to gradiate that down to the level of the week or the month. But I think it's a well taken point, and something that we've recorded the length of time that people are in these places, And we're definitely going to pull that string in the qualitative stuff. I think it's a reasonable assumption.
Thanks very much, Lawrence. Any last questions from anybody else in the chat? Seeing or hearing none, and conscious that I let us go a little bit long, and that the next sessions will be starting at 12. I want to thank you, Lawrence. I want to thank everybody, both presenters and attendees, for taking the time to come today. These were really interesting research threads, and very excited to see how this work continues. So there's going to be a 5-minute break before we get started next, and check out the link that Mohammed Hassan has put into the chat. Thanks very much again for your time and attention. Take good care.